evidence-based exercises at the time. But Judy didn't get better. And in fact, Judy wasn't at all motivated to do the program that I had developed for her. Luckily for myself and for my patients, I have spent the last 30 plus years learning more about how to motivate my patients. There's a lot more to patient care than just giving them the right exercises. I learned that the hard way. So today I'd like to share a little bit about what I've been passionate about over the last 30 years to help you, as Connie said, help your patients be a lot more motivated. First of all, I'd like to congratulate you for being here today and taking an interest in learning more about how to motivate your patients. Today, we're going to talk about improving patient engagement and motivation. We're going to discuss the role of warmth in patient-centered care, how to build the therapeutic alliance, and the importance of shared decision-making. Give me a thumbs up in the chat. I know that many of you aren't on the screen, but give a thumbs up to yourself or the people around you. If you've ever felt like you've given the right skilled therapy to a patient and they weren't engaged and motivated in the program that you had developed. Okay, let's be honest, our job is a lot more satisfying when our patients get better. I think we can probably all agree on that. Improving let's see, did I already say that? Today, I hope to inspire you to take a more active interest and responsibility in helping to motivate your patients to perform at their highest capacity. I think a lot of times it's easy in rehab not to realize that we have a responsibility in taking an active role in motivating our patients, not just expecting them to come in motivated. I'm excited many of you have sent in some examples of how you motivate your patients, and at the end, I hope to brainstorm together on how ways that we can better motivate our patients. We're going to do some fun exercises along the way. Some people think they're silly, but it's a great way to remember certain aspects of things I like to teach. So I hope you'll play along with me. Improving patient engagement and motivation. Okay, we talked about that. Let's go to the next slide. Treatment techniques alone cannot account for patient outcomes. Why patients get better or don't improve, why they stay motivated, engaged, or why they discontinue their treatment. Research continues to affirm the important connection between healing and human relationships. You've heard a lot about the clinical aspect of patient care from Sandy when she's talking about the pelvic floor, from Bill and Margaret. You'll be hearing a lot about from our neuro team and stroke and how they clinically manage patients. But today I'm going to take a little bit of a turn and talk to you about the connection between you and your patient. We call this connection the therapeutic alliance, and it refers to the sense of collaboration, warmth, and support between the patient and the provider. Better quality relationships between patients and providers are associated with improved clinical outcomes, improved patient satisfaction, improved adherence to home programs. They're also when we have better relationships with our patients and their families, they're more motivated to do what they need to do. They reach their goals faster, and they're more likely to return for treatment. Whether we like it or not, whether our patients like us impacts whether they get better. For some people, that's hard to hear, but it's really true. We really need to take an active interest in developing this relationship with our patients. Some providers naturally create this bond. It's like second nature to them. For this talk today, that I might be sharing things that will just help you understand what you're doing right so that you can do more of it. For others of you, maybe you struggle to develop a deeper bond with your patients. And I hope to be giving you some ideas today so that you can do better. One thing I'd love for everybody to do right now is just sit for a second and reflect on yourself as we're starting out. This isn't about judging yourself or saying whether you're doing something right or wrong. We're just trying to get an assessment, a personal assessment for yourself How successful do you feel right now, right in this minute, at forming a quick bond with your patients? 0 means, boy, Molly, I really struggle with that. And 5 means, you know what, I've done this a while, or it just comes naturally to me. So whether you're alone or you're with a group, just kind of hold up the number of fingers where you feel like you're starting. Okay, everybody kind of know where they're starting? Okay. For some of you, the conversation today, like I said, will be review. You can understand what you do well so that you can continue to do that. And for those others of you, it'll be learning what we can do better. Before we even are aware of it, patients are judging us and deciding whether they can trust us on 2 factors, competence and warmth. They want to know right away, will you help them or will you hurt them? And they're often doing this on an unconscious level. Competence is they're trying to decide, do you have the knowledge and the skill? In therapy, it's, do you understand the diagnosis and do you understand how to develop a treatment plan to help them? The other thing they're judging us on is our warmth. That's our personal engagement, our connection, our care for the patient. Are we friendly? Do we seem honest and trustworthy? Do we have empathy and kindness? Again, these judgments are happening very much below the level of the surface. So they might not be aware of them, and most often we will not be aware of them. It's really important that we want to balance these 2 traits. If you start to think about your own practice, you might be able to guess which side you weigh heavier on. Are you more of a technical person where you like facts and figures? Obviously, in the rehab setting, we all like facts and figures, but are you more like really easily connect with your patient? You might be a little bit stronger on the warm side, or are you more technical and specific and things like that? You might be more on the competent side. With our patients, one thing we really want to be able to do is to balance it. So we need to be really aware of ways that we can pull in. So if I'm on the more warm side, I'm going to make sure that when I'm with a patient, I am pulling up a computer screen that talks about their diagnosis and talks about different kinds of treatments. I might use some graphs or things like that to make the patient understand my more competent side. If I'm naturally more of a competent person, I'm going to make sure that I really use a lot of facial expressions, that I stop typing, that I learn about the patient. We're going to talk a lot about learning about the patient today. So really taking an effort and a personal responsibility in balancing these 2 traits in the rehab setting. If our patient's not getting better, a lot of times we think it's our skill, and that's why the patient's not getting better. But one of the things that's important to remember, it may not be our skill that we need to improve, but our connection to the patient. We need to practice our warmth. And one way that we do that is by practicing patient-centered care. Patient-centered care is when we think everything that we do, the patient is the center of it. We want to consider, who is this patient as an individual? We want to know what's going on in the patient's life. We want to know, how is the patient feeling? Are there things going on at work or in their families that we need to know about? We want to share power and responsibility, and we want to work to develop that therapeutic alliance or that warm bond with our patients. If you think back on the patient that I talked about in the beginning, Judy, I wasn't so good about thinking about Judy and her life, and I didn't really think about Judy's goals and what she wanted to be able to do. I was very narrowly focused, thinking about, okay, she's got back pain, she improves with flexion, I'm going to have her do these 5 exercises. And when we do that with patients, they're not motivated to get better. So thinking about the patient at the center of everything that we do, you will watch magic happen when we start thinking about that. So the first part of patient-centered care is thinking about who the patient is as an individual. You know, we are all individuals. We want to know, how do they spend their day? We want to know, what kind of support do they have? What have they been through? What kind of expectations do they have? What are their beliefs coming in, and what motivated them to come to therapy? So are these people single moms with 2 jobs? Are they CEOs that travel 5 days a week? What have they been through? So often in my practice, I just hear these horrific, traumatic stories. And when the patient always, I believe the patient has a strong desire to tell you their story so that we can understand where they've come from. And I don't know in Thailand, actually, I don't know whether you're typing or whether you're writing, but when a patient is sharing something very personal with me, I make sure that I stop typing and I direct my entire body to them. I make sure that I'm giving them a lot of facial expression and empathy and showing them that I am listening to what they've been through and understand, um, that been a traumatic event. I want to know what kind of support do they have available, and is this good support? What kind of expectations do they have? Like I said, are they coming into therapy where everybody in their family has had back pain, no one's gotten better, and they kind of think this is a waste of time? Or has the physician said, you know what, I do not think physical therapy will help, but I'm going to send you there anyway? When that happens, we do not stand a chance in the world, because working against somebody's beliefs of this is not going to work is a very steep hill to climb. One of the things that we can do for each other as healthcare providers is, if they're seeing another provider and you have a lot of respect for that person, is to just say, oh my gosh, you are so lucky that you get to see Sandy. Patients love her. She's amazing. I call it priming. You're not lying to the patient. You're just saying, hey, this provider is an excellent provider. It kind of helps the patient drop down their guard just a little bit. It's also important, why are they coming? How often do we have patients that when we ask, how long have you had this? And they say, oh, I've had it since the birth of my third child. And I'll be like, okay, well, how old is your child? 15. Okay, so what all of a sudden inspired you to come into therapy after 15 years of having the problem? Those are kinds of things that we want to know so that we can help motivate them at the level that they're at. One of the things that I always have to do for myself is check in with my own beliefs as I'm reading the patient's chart. And a lot of times, if I'm reading a patient's chart, I'm going to show you a couple examples coming up here where it's an 86-year-old patient. How often, when you read a patient that's 86 years old, do you think, okay, falls, I'm going to be working on walking, maybe some range of motion? But that's not always the case. And we need to remember that when we're seeing patients, they might have a whole different idea of what they want to be able to do. So this is a gentleman who is 86 years old. He runs 5 days a week. He runs with a group of 60-year-olds. I mean, the guy is amazing. Now, if you saw him, you would never think he was 86 years old. As I was reading his chart, I was like, okay, he wants to be able to run. This is not what I pictured that he would be able to do. Okay, another 86-year-old right here. There you go. That's how you use it. She wants to be able to walk safely with her walker. She's got 34 steps to get up into her apartment. She wants to be able to navigate those steps and get across a level surface independently. It's not my job to decide what the patient can do. And so often when we're working with patients in therapy, it's really easy to make our goals their goals, but that's not always the case. So as you're taking the history, I want you to remember that documentation really helps with motivation. And what do I mean by that? As I'm taking a history about the patient, I always say on the very first visit, you're going to see me typing a lot today. The reason I'm typing isn't because I'm not interested. It's because I'm so interested that I want to get every single thing down so that I can help you get better faster. The more information I take down, the more I know the starting place of where we're beginning. And patients love it when you say that. Then they want you to keep typing. If we just type while the patient's talking, then oftentimes they think we're disinterested, that we're not listening. So really helping reframe that up front is important. I take a lot of time writing down what the patient can't do. And the reason that I do that, or what they can do also, but specifically what they can't do, the reason that I do that, all the lights just went out, people, hang on. Turn the lights on, there we go. The reason that I do that is because I don't know if you've had this happen, but every day I have this happen multiple times, that a patient will say to me, I'm not getting better, but you can tell by the things that you're doing, and the patient is getting better. I said, okay, you're not, okay, let's go back about 3 visits. So I'll go back 3 visits. I'll look at my subjective. So I'll go, okay, you still can't climb stairs. Oh no, I can climb stairs. You still can't walk to the end of the block. Oh, of course I can walk to the end of the block. So when we're reading their words, all of a sudden, because they're the ones who said it, they're like, you know what? I am getting better. I didn't realize that I was getting better. So the more documentation you can take on that really helps with motivation. Another way that we can practice patient-centered care is developing that therapeutic alliance with the patient. And oftentimes we do this before we are even aware with our body language and by practicing shared decision making. It's always fascinating to me when I think about communication. More than 90% of our communication is conveyed by nonverbal. 7% is spoken and 3% is my tone. If I sat here on the talk today and I was kind of looking at my phone a little bit and maybe glancing over here and shuffling my pens, you might be reading my body language as very disinterested. Or if I showed my face looking out the window and was talking to you, if I was kind of slouching down, you might think I'm not interested in what I'm talking about, or I'm not passionate about what I'm doing. But if I'm sitting up straight and I'm using my hands to communicate, and when you say something to me that is important to you, I'm leaning forward, I'm showing you with my facial expression and with my body language how I'm feeling about what you're saying. So especially if you're having to wear a mask like we are, it's really important to almost overemphasize your body language, since 90% of it, the patient is learning to understand what you're saying. This one's also interesting to me, that in the first 10th of a second to 7 seconds, during that time, the patient is deciding if they like you. They're deciding, will you help me or will you hurt me? So before you ever approach that patient, make sure you take the time to realize that you can only make one first impression. And that's every time we see the patient. So remember that the patient is coming to see you, and kind of get yourself ready to make a good impression every single time. Put your best foot forward, or I like to do that for my patients. So thinking about the body language that we're giving, I realize that the body language that you have in Thailand is probably very different than that we have in America. And I'm really interested to learn more about that when I'm in Thailand in the fall. But one of the things that we pay attention to here, and I bet that you do a little bit there also, are the facial expressions. A smile is just such a universal, trusting, warm gesture that we can give to our patients. You know, we smile not only with our mouth, but we smile with our eyes. And so when we take the time to look at the patient right in the eye and give them a nice warm smile right when they come in, it's just a really bonding part to that therapeutic alliance, and I encourage you to do that. There's things that we can do that are offensive, and there's things that we can do that are warm and encouraging. Using hands in the United States is very important. So when we're meeting somebody for the very first time that we've never met before, we want to make sure that the patient can see both of our hands. And the reason that's important is because if I walk in, I don't know, let's see where, if you can see me. If I walk in and my hands are in my pocket, I hope you can see my hands in my pocket there, and you've never met me before, subconsciously you may start thinking, what is she doing with her hands in her pocket? Is she reaching for something? Or if I have a hand behind my back, subconsciously the patient may start to not trust me, but I may not be aware of that. So one of the first things that I always do every single time I see a patient, even if I've met them before, is I make sure that I have my smile on and I make sure they can see my hands. And then I know consciously and unconsciously the patient is going to have a better chance of trusting me with their care. And that's very, very important to me. Again, thinking about my posture when I'm with the patient. If I'm kind of slouched over like this and checking my phone, our pagers are on our phones. And so when my pager goes off, I'm saying to the patient, that's my pager going off on my phone. Excuse me for a minute while I turn it off. I don't want them to think that I'm checking my texts while I'm taking care of them. Head movements and hand movements. I can use my hands to describe what I'm talking about. If I say, I think it's going to take a little bit of time for you to get better, or I think it's going to take a lot of time for you to get better, I'm helping the patient to understand a little bit better what I'm talking about. If I'm listening to the patient and I'm nodding, I'm showing the patient that I'm listening by nodding. If they say something that's more heartfelt, I might put my hands here to say, oh my gosh, that hurts my heart. I don't have to say that, but by doing this, you're showing them in America. I realize that may be different in Thailand. You're showing them that that's a heartfelt thing that they're saying to you. How close we are to the patients. If I think about a patient when they come in, I'm really looking at their body language too. I had a patient named Henry, and he came in, he was very British, he was very buttoned up, he was soft-spoken. He liked a lot of personal space between me and him. I need to be looking for those clues right away so that I can make him feel the most comfortable as I'm treating him, and will eventually probably need to put my hands on his body. Then I've got a contrast of a patient named Kathy. She comes in, she's more like me. She's kind of all over the place. She's really loud. She likes to joke around. She's constantly slapping me. I can treat her in a very different way than I can Henry. But it's my job as the therapist to pay attention to the body language cues that my patient are giving to me. So we talked a little bit about that. Let's see here. So it's important to be aware of the nonverbal cues that we are sending to the patients and be aware of the cues that they are sending to us. One of the things that I am involved in at OHSU is I am the Service Excellent Ambassador. It's one of my favorite things about working at OHSU besides treating patients. And what I do is every patient at OHSU is send out a survey of their patient perspective of the care that they received at OHSU. So for all of rehab, when the surveys come in, and we get both positive, and we do get a lot of positive and negative comments. And I'll first read through the comment to see what the patient says. I'll open up the chart, kind of see what I think about the chart. Then I'll call and speak to the patient, talk to the patient about their story. Again, really listening to the patient and making sure that I'm understanding their perspective. I then go talk to the therapist and ask them their perspective. And then I put the two together and we come up with whatever we think is the best plan at the moment. But one thing that's always fascinating to me is it's often a disconnect. It's often a misunderstanding much more than it's a problem. And I'll tell you what I mean by that. So often the patient will say to me, that therapist, they weren't even listening. They were typing the whole time. They could have cared less what I was saying. When I look at the chart, I see lots of very specific details that the therapist has listed. When I go talk to the patient about a patient they saw a couple weeks ago, they'll be able to give me lots and lots of feedback about that specific patient. So I'm like, well, that's kind of interesting. The therapist seems to know a lot about the patient, so I know they were listening, right? But what do you think was missing? What was missing was the therapist letting the patient know they were listening. It's not enough to just listen and document. We have to listen and convey to the patient that we're listening. And again, ways that we can do that are not in the United States. Ways that we can do that are we can nod, we can smile, we can react to comments that they make. We might paraphrase what they're saying. These are all ways that we're building that therapeutic alliance so that patients feel like we care about them as an individual, that we care about who they are. And that's one important buy-in that we have to make sure that we get with our patients. Another thing that we really want to be doing as we're building this patient-centered care model is practice shared decision-making. And believe it or not, the research shows that we do not do a very good job of this in rehab. We're good at coming up with goals for the patient, but we're not always good about having the patient participate in that shared decision making. So shared decision making is when the best evidence treatment is combined with the patient's values and preferences. Remember that I talked a lot about in the very beginning, taking that extra time, even though it takes time away from the treatment, learning about the patient's values, learning about what their preferences, understanding what their life looks like, what have they gone through. That's all going to help you start to formulate this shared decision making. Create goals and treatment plans with the patient instead of for the patient. Like I said, with Judy in the very beginning story I told you when I was a brand new therapist, I didn't do a good job of involving Judy in her own care. I was like telling her what she was going to do, which I can't imagine that I would like that any more than Judy liked that. So before the patient can be participating in that shared decision making, they need to be educated. They need to be taught about the various options available to them in physical and occupational therapy. That might mean what, hey, we can do exercises lying down, sitting up, standing on your head. I always tell people there's what positions are you most likely to do exercises in? What does your day look like? Even though it may not be best for a new mom to be lying down, do their exercises, if they're going to do it lying down with their baby when their baby's doing tummy time, I'm going to give them a lying down exercise. I'm going to give them whatever they want, because when we practice shared decision making, they're going to be more motivated to do the program. So helping educate the patient. An educated patient is an empowered patient. Again, does it take a long time? It absolutely takes a lot longer than not doing that, but you're going to get the buy-in, you're going to get the patients coming back, you're going to have very satisfied patients who are more likely to get better. We want to encourage the patients to get involved early on in their care. Physical, occupational, speech therapy, we're taking an active role. The patient, because they're going to be doing these things for a lifetime, shouldn't be taking a passive role in their care. Hang on, I have one quick drink of water. So one of the things when we're taking this objective is listening for what kind of specific goals the patient wants to be able to do. What is meaningful to the patient? Patients are much more likely to follow through on goals they were part of setting. They're much more likely to be motivated when they know they are working towards their own goals and not just your goals. When they perceive the exercises as important and most important, individualized. So we want to think about what does this patient specifically want to be able to do? Really listening to what they're telling you. When do they want to be able to do it by, and why do they want to be able to do it? So it's interesting. I was walking through the clinic the other day, and I heard one of the experienced therapists saying, okay, here's my goals for you. And you could see her stop in her tracks. And she said, oh, wait a second, let me back up. Those are my goals for you. But what are your goals for you? Because your goals supersede my goals. And I, of course, loved hearing that. So we want to know, what do they want to be able to do, specifically do? Do they want to be able to run 20 miles? Do they want to be able to go up 20 steep steps? Do they want to be able to get off the floor? And when do they want to be able to do it by? Hey, I got a family reunion coming up. I'm a football fan and I got to be able to climb up those bleachers. Whatever, the birth of my grandchild is coming up. Whatever's coming up, you want to know, is this a realistic expectation of when they want to be able to do it by? And why do they want to be able to do it? Knowing your why will keep you motivated when you want to give up. I think I say that 500 times a day. And I know this for myself as well as for my patients. Know your why, and you will not be likely to give up. This is one of my very favorite stories. And I had a grandmother, and she came to me, and she was a 76-year-old, and she was like, Molly, I start off by doing my exercises. I do a great job, and then I stop. And then I stop, and then I beat myself up, and I just eat ice cream all day long, and I tell myself that I'm a loser and I'm never going to get better because I can't follow through on my exercise program, and why do I even try, and I should never go to physical therapy, and I'm sure Molly hates me. And they're coming up with all this internal dialogue simply because they stopped doing their exercises. So I started talking to her, and I was like, okay, why do you want to be doing these exercises in the first place? And she's like, I want to get stronger. Okay, great. I love the fact that you want to get stronger. Why do you want to be stronger? Well, I want to be able to get around easier. Okay, great. I love that you want to be able to get around easier and be stronger. But why is that important to you? Well, I want to be, because I need to live a long time. Okay, I love that. You want to be strong, get around easier, and you want to live a long time. But why does that matter to you today? And all of a sudden, she burst into tears. I mean, she cried for 20 minutes probably. And she said, I need to do this, Molly, because I need to be there for my grandchild. I need to be there. So all of a sudden, we got down to a deeper emotional level of why somebody wants to be able to do their exercises, why that's important to them. One exercises I do personally, I encourage you to do them yourself and with your patients. Take out a 3x5 card. On one side of the card, write down whatever your goal is. On the opposite side of that card, take a picture. In this case, I had her put a picture of her and her granddaughter. And anytime you feel like you don't want to do your exercises, pull out your 3x5 card. And it's going to remind you why you want to do your exercises. It's a very, very effective tool. When we write down our goals on that 3x5 card, just the fact of writing them down, we have a 42% higher chance of reaching our goals.
Mr. Tun says, keep it meaningful. Can we use the PSFS?
You can absolutely use the PSF. I use it all the time. I think it's a great one because you're listening to what the patient says and you're writing down specifically what the patient says. Now, one thing about that outcome form that I want you to think about is oftentimes if the patient will say, and we'll talk a little bit about this coming up, the patient will say, I'm not better. And sometimes what they're saying is, I'm not perfect. I don't know if you've ever heard patients say that. Okay. So I'm not better sometimes means I'm not perfect. And so helping patients move along that scale with specific examples. Does that help?
Yep, that's how we taught them.
Okay, good. Okay, perfect. Any other questions on that?
How often to reassess on the PSFS?
I think on that, what I do is I'm listening to my patients. I'm listening to what they're telling me. You know, we have patients that come in and they're like, wow, this is crazy. I've had this pain for 10 years. You give me 3 things to do, and I haven't been in for 2 weeks, and I've made such a big jump. So you're writing down, obviously, what the patient can do. How big are those goals? How small are those goals? That's going to be determining how often. I mean, every single time the patient comes in to see me, in my mind,
เกิดเลยเลทไปถึงประมาณเวลาเนี้ยไอ้ตรงทางเข้านั่นน่ะ
Please mute.
จำได้ไหมวันนั้นที่เราไปอ่ะเรา
Okay, I muted.
okay. In my mind, I'm always saying, so it depends on how big of a goal it is. I'm every time the patient coming in, I'm looking at, is the patient making progress towards the goal? Have I given them the right exercises? Are they getting closer to their goal? If you notice that the patient is getting closer to their goals, you really want to call attention to that. Hey, look at this. We wrote down this goal on this outcome form and you're moving closer to it. Do you feel like you're at a point right now? Let's say it's 3 weeks out. Do you feel like you're at a point right now where this number has changed? Does that make sense? Okay. Let me know if you have any more questions on that. I'd be happy to back up on that. Another thing that's very, very important, I'm big on outcome forms. I'm really big on showing the patients how they've changed, but I know some of the questions that came in about outcome forms and not meaningful to the patients. And I will be honest with you, outcome forms are not very meaningful to patients. We love them because they're meaningful to us. Insurance companies love them because they're meaningful to them, but most outcome forms are not motivating to patients. So I like to show patients their progress, but I don't personally use it as a big source of motivation or encouragement. But that's my own personal. But I definitely use them. I definitely document with them, and I definitely show progress with them. One thing again that's really important, and please jump in anytime you have questions. I love it when people are interacting. Another thing that's really important is that we show the patient that it's meaningful. Again, when I'm thinking back to those survey forms that patients are writing in, I'll talk to people on the phone and they're like, my therapist is, she doesn't even listen to what I'm saying. She's not working towards my goals. She's working towards her goals. And I'll say, okay, well, tell me a little bit more about it. And they'll be like, I want to be able to get out of a chair. And she's giving me some knee extension or some bridging with a band. Okay. So what happened there? The patient was, the therapist was competent, right? They were giving them evidence-based exercises, but they were forgetting the warm side of the treatment. They were forgetting that they need to tie those exercises back to the patient's goals, understanding that the patient, that we're working towards that individualized plan for the patient. So again, make sure the patient knows why you're doing the exercises that you're doing. It's very obvious to us. It is not to the patient. Sometimes it's really hard to be a therapist. This is an example. I had a patient come in. She was 25 minutes late for a 40-minute appointment. And she was not in the best of mood. She was in a hurry. She was having a lot of pain. Let me get this light on again. She was having a lot of pain, and I was like, okay, I've got to think about how I'm going to be able to help this patient. So I decided, I was watching her as she walked in. I could tell about her balance. I could look and see how she was moving when she set things down and when she picked things up and when she walked over and sat in front of me. I was getting a lot of information without testing it. When I took the brief history, she's like, you know what? Our whole family just got done with a bout of the flu. My back is killing me. My husband's going out of town and I'm going to be at home with 3 kids for 2 weeks. I got to be able to pick up my kids. So I've got to think, what's more motivating to the patient? Am I going to sit there and test her strength and her range of motion and do things that she's already mad coming in, hasn't even started yet? Or am I going to listen to the patient, think about patient-centered care, think about patient preferences and what she really needs, and give her ways? Her only goal was, how can I pick up my kids without pain? So I skipped all the boxes, skipped all of this, and simply worked on helping her pick up her children without pain. She was the happiest patient in the world. She kept coming back and coming back. Had I decided to do something differently and just stick to the evaluation, I doubt she would have come back because I wouldn't have been listening to what she needed. Okay, another thing that we really need to pay attention to when we're motivating our patients is their learning style, their preferences, and their understanding. We need to remember that there's a lot of different ways to learn. So one of the things that we need to know is how the patient learns best. And I'll tell you, the patients don't always know how they learn best. And it isn't always the same every single time for every patient. You know, some people go, oh, I'm an auditory learner, I'm a visual learner, kinesthetic learner, but not, maybe they aren't every time. Maybe in different situations, that's a constantly changing situations. So we need to know how the patient learns best. We need to make sure the patient understands what we're saying. I can't tell you how many times I've been treating a patient when they were nodding, they were looking at me, and I knew that it was everything I was saying was just going straight over their head. So as I'm teaching the patient, I'm going to be using my words. I'm going to take them through the exercises. And oftentimes, to make sure they understand, I'm going to have them teach that exercise back to me so that I know that they caught those little nuances that make the exercise. Say, like a clamshell. I want to make sure the patient heard that I said, don't roll your hip back. We need to keep that hip forward so that when they're teaching it back to me, I'm watching. Do they understand the exercise? Because people don't want it. They're too embarrassed to tell you that they don't understand when you just spent 10 minutes teaching them. Again, as I mentioned earlier, we want to know, how does the patient like to exercise? Even if that might not be in the current concepts. If they're not going to do their exercises, they're not going to get better. So maybe they hate bands and you think they should have a band. Maybe they want to be able to lie down. Maybe they'll never go to the gym, even if you paid them to go to the gym. We need to really listen to what the patient is saying and how they like to exercise. Okay. When we do, one of the things that I always teach my patients, and I think about myself when I'm doing something different, is when we do things differently, it feels unfamiliar. And our brain tells us, our mind tells us that it's dangerous and to turn back to the way that we've always done it. We're going to do a really fun exercise that I love to do to myself and with many of my patients all the time when I'm doing something new. So that when we have to remember that we're meeting our patients at a time when they're really vulnerable. They don't feel super confident. So they're really stretching themselves to make a goal. They're going to feel fearful, maybe they're going to feel out of sorts. And so when they haven't been putting weight on their leg for a month, and then all of a sudden we tell them to put weight on their leg, their brain is going to say to them, don't put weight, it's dangerous. Or if they usually walk with their feet too wide and we haven't put them close together, it's going to feel unfamiliar and they're going to want to turn back to the way it was before. If all of you, all of a sudden, I don't know if you drive to work or walk to work or take the train or whatever you do, but if all of a sudden you decided to do things differently when you woke up in the morning, did them in a different sequence, your mind would start telling you, no, that's wrong. It's not wrong, it's just different. It's just unfamiliar. Before we go on to do that exercise, I want to tell you real quick about a patient who came in. This is about learning style. And outcome forms, since we were just talking about outcome forms a minute ago. So she came in, I did the tug, the timed up and go, I did the 5 times sit to stand on her. Both showed that she was highly significantly at risk for falls. She could have cared less what that form said. It could have said, you're going to fall tomorrow, and she would not have cared. It was meaningless to her, even though I showed her what norm was, even though I said, you are at high risk for falls. It was not motivating to her. I gave her exercises. We talked about it 100 times. She was very fancy. She loved to get fancied up. She loved fancy shoes, kind of like your purses, kind of, but shoes. And one day I decided I got to try something different because what I'm doing is not motivating to her. So what I decided to do was ask her to bring in a pair of sneakers. She brought in a pair of sneakers and I videoed her for 1 minute with the sneakers and 1 minute with her fancy shoes and had her watch the videos. I never had to mention it again. She got rid of all her fancy shoes and she got some fancy sneakers. For me, it was my responsibility to keep digging down. Outcome forms didn't work. Talking about it didn't work. Telling her that she might hit her head didn't work. I had to keep trying new things until something helped her change her behavior. Okay, so we're going to do a fun little exercise. Let's just see how it is. Okay, so what we're going to do here is I'm going to show you a video in a minute, but what you're going to do, if you want to turn your cameras on, you can, because it's kind of fun, but you don't have to.
Let's have them all turn their cameras on.
Okay, everybody turn your cameras on. Connie, you're so good. She's so strict.
Yes, I'm strict. Hello.
So
Thank you
Look
very
at all
much,
the
Connie.
good-looking people.
hello, people. So nice to see some faces. Okay, so when we do this exercise, what we're going to do, we'll watch the video and then we'll probably watch it again. And I'll explain it in just a second. Okay, so in a minute, you're going to take your hands and you're going to fold them together. You're going to look down and you're going to see which thumb is on top. Then you're going to unfold and you're going to do it again, unfold, do it again. Each time checking to see which thumb is on top. It's easy to want to kind of manipulate it and change things around, but if you can, try not to actually force which thumb. Just let yourself do it. Okay, so I'll talk you through it. Ready? Here we go. Everybody fold their hands, look down, see which thumb is on top. Unfold your hands. Everybody fold your hands, look down, see which thumb is on top. Unfold your hands. Everybody fold your hands, look down, see what's on top. Unfold your hands. How many people, and there's no right or wrong answer. So if you did not get this, if this did not happen to you, you were doing nothing wrong. It's just some people respond differently. How many of you had the same thumb on top every single time? Many. Can you see how many, Connie? Because I can't see that much from mine. Did very many of you have the same thumb on top?
I can't see them raising, but I can tell you I had the same thumb every time and I tried to switch it and it was awkward, so I switched back.
Okay, so What we're going to do now is we're going to take, let's pretend like you had your right thumb on top. Now what I want you to do is I want you to put your left thumb on top. Remember, you're going to fold your hands like this woman and hold it there. So it's the opposite thumb. If you always had the same thumb on top, it's the opposite thumb as the one that before. And just make yourself hold it there. For many people, when they do this exercise, their brain tells them that they want to switch back to the other thumb on top. Was that something that you experienced? Okay, I got some head shaking. Woo! Okay, so when we do things differently, our mind tells us to turn back to the way that we've always done it. There's no difference between left and right thumb on top, right? It's just a different way of doing it. So that when we're asking our patients to do things differently, move your arms more, put more weight on your left side, turn your head, whatever we're asking them to do, if it's different from the way they've always done it, they're going to resist the change. That's normal. It's normal to resist the change. So we just need to be sympathetic for them. And a lot of times I'll have them do this exercise and say, no, it feels weird when we do things differently. And once they do this thumb exercise, they're like, okay, I got it. It feels different, unfamiliar when I do things that are unfamiliar. And it will feel that way when I do the exercises or move differently, and that's okay. I hope that that exercise did not get lost in translation and everybody understood it. Okay, so we got that. So how do we sustain motivation when we have patients that are coming for a long time and maybe at some point in their therapy we're seeing them once a month, or they're going on vacation, or they're not always with us? Remember, we want our patients to take an active role in their care, right? And so one of the things that we need to think about is, how do we keep the patients going even when they might want to give up? One of the best ways that I know how to do that is by getting an accountability partner. And I do this for myself, for my own goals, and I encourage my patients on the first visit to find an accountability partner. And what that is it's somebody that you can call and check in with, or text and check in with, or send an email and check in with, to tell them that you're doing what you committed to doing, whether that's drinking more water, walking for 15 minutes, doing your PT exercises. If you get yourself a partner who's interested in you as a person, who's interested in having you be successful with your goals, and you share your progress with that person on an ongoing basis, your chances of reaching that goal increase by 76%. I want my patients to be successful. I want them to have that advantage of having an accountability partner. I'm one of their accountability partners, and I want them to have another one so that they can continue to be successful even when they're done with therapy. I had a mom, every single time she came in, I said, did you do your exercises? Nope, didn't do my exercises. When people don't do what they're supposed to do or what they think they're supposed to do, they feel bad about themselves, right? Their self-image kind of goes down. They feel like a loser. They feel like, why do I even try anymore, right? And so with this woman who was never doing her exercises time and time again, and I could tell she wasn't ready to be done with therapy. She just didn't know how she was getting in her own way. I said, how about we find you an accountability partner? She had resisted it at first. She's like, you got it. I'm going to get myself one. I just ran into her in the grocery store not very long ago. Now it's been 2 years, and she has the same accountability partner. And after she got that accountability partner, I never once needed to prod her to do her exercises. She was just internally, it was for her very motivating to have a guide by the side. And with nowadays, since COVID, you can do that on a Zoom call. You can do it by text. You can do it by email. Some people like to do their exercises with a friend. So another thing that we can think about is a success log.
จ้า
Okay,
จะทำอยู่แต่ว่ามีคอนเฟอเรนซ์จ้า
is that for us, Connie?
They just muted.
Oh, okay. I just want to make sure it wasn't a question. Okay, so a success log is, let me just pull up this note. A success log is where we celebrate our successes. I do this personally with my own professional and personal goals. When I'm doing something and I'm creating success in my life, I write it down in a notebook. And the reason that I do that is because there's going to hit a day, like I always hit, and like your patients will hit, where they think, I'm not getting better, I'm not making progress, I'm frustrated, why do I even do this? And I'd pull out my little notebook and I'd say, I'm not doing so bad, I'm actually making some positive changes in my life, right? We need to celebrate the things that we do right. When we're writing goals in the patient's chart and we write met after the goal, we are, you know, in a way celebrating that the patient has met the goal. But oftentimes we don't always tell the patient, hey, look at this. You met the goal. That's awesome. Let's just stop for a second and think about how long it took you to get here and everything that you did in order to get yourself here, and really acknowledge all the work that they put in, because it is worth celebrating. I learned that one from Nancy Durbin, who's a physical therapist. I don't know if she's ever spoken with you, up at Dornbecker. And my son, when he was a young teenager, had CRPS for his arm. And it was very difficult for me to motivate him to do his exercises because he was in a lot of pain. Every time he did his exercises, he had more pain. And he went up to physical therapy up and saw Nancy up in at Dornbecker, and she was so smart. Again, meeting the patient where they are. She showed warmth and compassion for him as an individual. He loved to talk about Starbucks drinks. And so she said, here we go. We're going to make a deal. We're going to celebrate our successes, celebrate your specific successes. If you do your exercises for the month that we lay out together, once a month, we're going to go down to Starbucks in the lobby, and you can have whatever drink you want down there. He was the most motivated teenage boy I have ever seen. So it doesn't need to be something that you buy for your patients, but encourage them to celebrate when they do something well, because they put a lot of effort into getting there. And lastly, thinking about outcomes. You talked about patient-specific score, which I love that outcome form because it's specific for the patient. But one of the things that I often see is patients, as therapists, we are using outcome forms that patients do not care about. They do not care about all these forms they're filling out. They rarely care about if they've made progress on those forms. We know what they mean. Insurance companies knows what they mean, but the patients often don't really care. So remembering that as you're showing the patient, hey, look, you're doing so amazing. Your 5-time sit-to-stand test was better. Again, is that motivating for the patient? For some patients, yes, but for many, no. So the patient-specific functional scale is much better at working towards the patient's goals, patient-specific goals.
The only
Yeah.
thing I would say to that, because I would tell you that BDMS is amazing at utilizing functional and patient-reported outcomes to be able to show the success of their programs as a private hospital, is that if you make the test meaningful to the patient, to show them the progress they made and they understand it, it can be meaningful.
I think I 100% agree with you, Connie. It can absolutely be meaningful, but not always just by itself.
Of course, you never by itself, right?
Okay. So I definitely agree with you, but a lot of times when people call me to problem solve about patient motivation, and they'll be like, I'm showing them all these tests that they're improving on and they don't care. So using it as one part is important. And Connie has told me that you do an amazing job of using outcome forms. So good job. That's very, very important. So thinking as you're, just to kind of summarize that part, thinking about why patients don't engage. Have we considered what's going on in the patient's life? Have we given them too many exercises? One thing that I think often happens in rehab is they're seeing PT, OT, and speech. And we might think I might think as the PT, I've only given them 4 exercises, but so has the OT and so has speech. They're going to 2 doctor's appointments. They have a family, they have a job. Excuse me, all of a sudden those 4 exercises are too overwhelming, so the patient stops doing the exercises. So really thinking about what other disciplines the patient's seeing. Again, the goals are not important to the patient. They don't understand the exercises. They don't understand how the exercises will get them to their personal goals. All right, yay, we finally get a break. So I hope that you'll take just a few minutes. You can stand up, stretch a little bit, and if you need to use the bathroom, I hope you will do that. How much time should I give them, Connie?
Well, I would like to see if anybody stays on, if they have questions as well to you.
Absolutely, absolutely. I would love that.
And I think I would give them till 3 minutes.
3 minutes?
Yeah.
Okay, 3 minutes it is. So we'll be back in 3 minutes. Please take the time to, stand up and stretch a little bit. Maybe move your body, get your spine, get a little movement, go to the bathroom, whatever feels good to you. But as we're on here, I love that. Woo, okay, now we're starting some movement. All right, any questions while we're sitting here? I'd love to answer some questions. I'm going to stand up myself because I think it feels good to stand up a little bit. Any questions from anybody? Connie, can you see the chat, or we can have them turn on their microphone?
Yeah, there's nothing in the chat, but Mr. Tun has agreed that the different people will share their case studies with you for motivation.
That sounds great. That sounds great.
So when we get to that point, we'll have them turn on their cameras. Okay, I see. In case of poor progression, how we can encourage them. Can you please help us?
If they have poor, I think I understand. If you're finding that they're not progressing with their program, is that the question?
Yeah, and poor clinical outcome probably.
So number one, maybe we haven't picked the right clinical outcome. And it's maybe not motivating to the patient. Again, making sure that you've really taken a good subjective and understanding what's important to the patient, what's going on in the patient life. Is there something going on in the patient's life that you're not aware of, that's a significant event? And is that keeping them from doing their program? Do they not like the exercises that you gave them? Do they have some depression going on? How do we motivate them? We sit down with them. One way to do it is to sit down with them and to really say, am I not working towards something that's important to you? What do you really want to be able to do? I'm not sure if that's helpful or if that's something that you already are doing, but really digging down and asking more than just one question, like I did with the patient with the shoe, not with the shoes, but the person who was the grandmother who wanted to be able to get off the floor, like asking that patient, why do you want to get better? What's important to you as a person, right? And understanding their why. And have we totally missed the mark on that? I'm not sure if that answers the question, but that would be the first thing that I would do.
That's great. And then what about if their expectation is unreasonable? So somebody that's not going to walk.
Right. So if somebody's not going to walk or their expectation is, I don't personally ever tell a patient that they're not going to be able to do something. If their expectation is off, what I'm hoping is over time that is going to be more obvious to the patients. I've had many patients over my 35 years as a therapist who have done things that I never thought they'd be able to do. So in medicine, obviously, there are ways that they're not going to be able to, like that they're paralyzed or something. They're probably not going to be able to walk. But starting off by encouraging them to look at things that they can do. Okay, let's build up things that you can do and see what kind of progress that we can make. That's what I would say.
So for example, build strength in their legs.
Let's see tiny steps that we can make that will work towards that goal as we move along. So if somebody wants to be able to walk, build strength in their legs, and then, okay, how about can you stand? Okay, if you can stand, how about can you shift weight? So we're taking steps towards what their goal is, and the patient can see the kind of progress that they're able to make.
And so I've always had this question on the PSFS. Would I break down the steps so they could see the success, or do I just leave, I want to walk?
Well, I'm interested to hear what they do. I know what I do. Let's ask them first and then I'll tell you what I do. How's that?
Hun, what do you do?
Connie,
Yes.
please explain more a little bit.
Okay, so on the patient-specific functional scale, do you just put the patient's goal is to walk, or do you break it down into steps of success to walk? Do you just say he just wants to walk?
Yeah, he just wants to walk. Then
Okay, and that would be the goal.
the goal just want to walk. It depends if the patient on the assessment first. If the power of the muscle is not so well, that's why I tell them to a short goal for the strengthening or a little bit endurance. Then they can stick to stand. If okay, try them to a little bit step, then try to move a little bit. Have a short goal of distance first. They can walk 1 meter, 2 meter or not. That's why I can use the Molly's technique that the progression is improve meter, improve 2 meter. Then we ask the patient that what's your goal? If you go like to walk from bed to toilet, it have a distance 3 meter. That's why if they can walk one, okay, it's not enough distance. We'll try to make a little bit strengthening or endurance of the walking muscle. That's why until they can walk to the toilet.
Thank you. And
Yep,
Molly,
you're welcome.
how is
Right.
that?
That was awesome. I would always break it down because it would be like if we use a non-PT example, if somebody's trying to save, $5,000 and that's their goal, and they haven't hit that goal, they're just going to be more discouraged and more discouraged and more discouraged, and they're not going to be, if that's their big, huge goal, they're not going to see any movement. But like he just said, hey, I couldn't sit to stand before, and now I can sit to stand. I couldn't walk a meter, and now I can walk 2 meters. So it gives we can celebrate the successes. They can see progress. If the goal is too big, the patient doesn't understand that they're changing when they really are.
Awesome. The next question, do we need to make a decision making together with patient every time?
I believe that if your patient is coming to therapy, you want their buy-in. If you don't have a buy-in from the patient, they're not probably going to do what you say. What do you mean? I mean, do we let them decide every time? Is that what you're saying?
No, I think you answered it right because you're making the decisions together every time because it's the patient's therapy session, right?
The patient, I'm there. I practice patient-centered care every single time the patient is in front of me. My job, I believe, is to provide everything for that patient. Everything that that patient wants to be able to do is what I'm working towards. Now, I might have some other things I'm working towards also, but that is my focus.
Okay, in case of the patients who don't know they're meaningful or they don't want to express it, how to facilitate them to express or state what's meaningful to them.
I think maybe going back to like are you saying they wouldn't want to say, I want to, it could just be that they don't know, Connie, also.
Yeah, that's a
It,
good point.
it's often that they don't, like that woman who was cried for 20 minutes. She didn't know in her heart why that was so important to, but she did figure it out. So it's remembering that even though we're supposed to be therapists who are working on the strength and the range of motion and this, we can do a lot of exploring and talking while we're doing those things with the patient. And really help them explore what their own preferences and values are. And sometimes it, just like with ourselves, it takes some digging to help them figure that out. It's not always that they're being resistant, it's that they don't know. I don't know if I answered that question. Did I answer it, Connie?
Oh, sorry, I was on mute. I said good one. How to deal with the difficult patient who rejects everything.
Lots of patients are going to reject everything. You know, I have a good story. I had a patient come in, he would do nothing. That guy, I didn't care what I could have offered him the moon. He was not doing anything. So finally he said to me, I will get on the bike for 30 seconds. I said, 30 seconds? And he's like, yeah. I said, okay, great. Now I'm just going to show you on my phone how long 30 seconds is, just so we can all see what this man was doing. Okay, ready? We're starting 30 seconds. Right now, he is on the bike for his 30 seconds, and this is what he committed to doing. Okay, and what I had to do was I had to be okay with the fact that he wanted to ride the bike for 30 seconds. Okay, we're halfway through our 30 almost done with our 30 seconds. And 30 seconds. That is how long he committed to riding the bike. Okay, so sometimes breaking it down so small that we would think like, what a waste of time. That guy, every single time he came in, he said, I will get on the bike for 30 seconds. I wasn't like, how about 45? How about 2 minutes? Why only 30 seconds? I was like, 30 seconds? That's so awesome. Let's go get on the bike for 30 seconds. He did that for the first 5 times he came in. Then all of a sudden, I think he developed this trust with me, like I cared about what he was willing to do, what he could do, what his psyche would let him do. I see him all the time now. When he's coming in for appointments, he'll always stop by and say hi. And he rides the bike for 45 minutes, 4 times a week. I had to start with 30 seconds because that's where he was willing to start. So
That's amazing.
if somebody's resisting, stop pushing back. Just kind of lean back and let them try to figure out what they are willing to do. And when you do that, you'll see the patient kind of soften. When we chase after a 2-year-old, they run. But when we stop, they come towards us, right? So the same thing is often true for patients.
ไม่น่า
When you
มี
stop pushing, sometimes they'll be a little bit softer with
ยัง
us
ยัง
also.
ไม่ได้กิน
Okay, one more question before we go from break to your next slide.
Okay?
How do you detect and deal with patients
เอาห้อง
who
นี้ก็เปิด
want
เหรอเอาของพี่จุ๊บ
secondary gain? Please mute yourself if you're not talking.
I know, start again because Connie, I couldn't hear. I'm so
Okay.
sorry.
How do you detect and deal with patients who want secondary gains, whatever it is, such as from family, from insurance, etc.? How can you detect or deal with that?
I don't think that we can ever 100% detect. So I am just reporting consistencies, and I do a very good job of documenting what I'm seeing. I like, watching what the patient does on the way in before they're ready for the actual test. You're watching for inconsistencies. Are they walking perfectly as you're distracting with a conversation? But then when you go to actually do a test with them, they all of a sudden have a limp going on or they trip a couple times. So I am making sure that I'm watching as much during the testing as when we're doing other things, maybe working between. It's not my job to decide if somebody else is being dishonest. It's my job to document what I observe in therapy, or that's my belief. How about other people?
What do you think, Dr. Sushila? Are you there?
Yes. Because sometimes we have patients who want to be admitted longer than we said. So how can we deal with that? I use the outcome measurement, but sometimes it doesn't help.
I see. I think I understand the question a little bit more with your answering that. Is it fear? Is it a patient's fear why they don't want to go home? That's a question. I don't
Maybe
know.
that's one reason.
That's one reason. Okay. So kind of
Sometimes most of them are the middle-aged patients.
Molly, you could research that and get back to us. I could send it on and introduce you to Dr. Sushila.
I would love to discuss that more because I can generate and research and think a little bit more about it for a longer period of time. And I bet that the two of us could have some pretty fun conversations on how to help patients work through. And actually what we're going to talk about next might play into it. Some of it is the patient's thoughts and beliefs about maybe what might happen, or it could be totally unrelated. They want to spend more time in the hospital.
And can I ask you one more question?
Me? Sure.
How many meaningful goals should you set per one rehab session?
I'm listening to what the patient is saying, and I'm probably, the most I would write down is 5, but a lot of times it's 3. But if they're rattling off, I want to make sure that I'm listening to what they're saying. And maybe if we have 5, maybe we're going to meet one before the other. So that's going to help the patient stay encouraged and motivated. But I'm curious, how many goals do you all set at a time? Any magic numbers? How many goals do you feel like you're working towards at one time?
Normally I did 3.
3. Okay, yeah. 3 is a great number. Thank you for that. Anyone else? 3 to 5? Okay, great.
Okay, move on, Molly, because they're
Okay.
going to share their case studies with you at the end.
Yes, I'm going to be speedy quick through this. Okay, so let's see here. We're going to shift gears a little bit. So we've talked about the first 7 seconds. We've talked about shared decision making with goal setting. We've talked about how to increase the effectiveness of patient education and make sure that we're working towards the patient goals, the patient understands us, that all the things that are important going into motivating the patient. Now we're going to talk a little bit about the internal aspect of patient motivation. What's going on in the patient's mind that might be getting in the way of the program, this may be one of the things that's getting in the way of the patient wanting to leave. Give me a thumbs up in the chat. How many of you have, or just now that for those of you that are still on the camera, how many of you have patients that experience stress, anxiety, frustration, or self-doubt when they're going through rehab? It's common, right? It's a very common thing. We're working with people when they're at a very low time in their life. Patients often become less motivated and less interested to coming back in rehab when they're experiencing those symptoms, right? It gets in the way of productivity, their own productivity towards their goals. But have you ever thought about what is causing that stress, anxiety, and self-doubt? One of the reasons I'd like to talk about today. We have up to 70,000 thoughts a day. 70,000 thoughts is essentially how we talk to ourselves. 90% of those thoughts are the same thoughts we had yesterday. And up to 85% of those thoughts are negative unless we take control. You may be thinking, why do I care? And what does that have to do with motivation and physical therapy or occupational therapy, speech therapy? You see, our thoughts influence how we feel. And how we feel impacts our actions, our choices, and our behaviors, which ultimately creates our results, creates our success, our demise, right? It's really important. Carol Dweck, a well-known psychologist and researcher out of Stanford University, believes that mindset, what the patient believes, is the greatest predictor of success. Patients believe what they hear themselves say. And that's really important that we start listening to what our patients say, because they're setting themselves up for this cycle of success or of failure. We want patients to understand how their thoughts are impacting their results. So if you have a patient that comes in, they're feeling great about their program, and they're like, hey, their thoughts are, I'm getting better. They're likely to feel more hopeful, more motivated, more inspired, more encouraged. They're likely to take actions consistent with those feelings, doing their exercises, of following through on what they're supposed to be doing. And because of that, they're going to get better results. They're going to improve. And when they improve, their thoughts are going to improve. If, on the other hand, we have patients that have negative thinking and they start to think, I'm never going to get better. Everybody in my family has back pain and nobody has gotten better. Or my doctor said I was never going to get better. I don't even know why I'm here. They may be feeling sadness, frustrated, very unmotivated. Their actions might be to blame and complain instead of focusing on actually following through on their exercise program. So their results, their success, they oftentimes will not improve, leading to more negative thoughts. So it's really important that we help our patients understand how the things they're saying to themselves are impacting their motivation and their follow through with their exercise programs. Okay, it's hard. This is one of my favorite exercises, so I really hope everybody does it because it's kind of fun. Okay, it's hard to hold the image of one thing in our mind and try to do something else. In other words, it's hard to say to ourselves over and over again, I'm terrible, I'm never going to get better, no one in my family has ever gotten better, and then behave as if I'm somebody who is going to get better, following through on my exercise program and things like that. We need to hold the image in our mind of what we want the path to look like going ahead. We're going to do an exercise I called seagulls and jackhammer. So first I want everybody to notice this lovely bird flying in the sky, which is called a seagull. And it's gliding above in the sky, above the beach, down at the Oregon coast, just having the time of its life, okay? What I would like everybody to do is I would like everybody to stand up. This will kind of get everybody moving, and hopefully you could turn your cameras on. I would appreciate that. So stand up, and in your mind's eye, as you're standing, are you guys standing? You look like you're sitting down. Okay, stand up.
Turn your cameras on.
Turn your cameras on and everybody stand up just for this exercise. It'll get you moving. It'll get you feeling better. We're going to have a little fun. I like to have fun while I'm working, and I hope you do too. Okay, so I want everybody, first of all, to picture, hold the image of a seagull in your mind. I want you to just, you can close your eyes if you feel safe. If not, just kind of look down at the ground. And I want you to hold an image of a seagull in your mind. I want you to picture that seagull in your mind gliding above the sky. Okay? Then what I want you to do while you're holding the image of the seagull is I want you to move your body as if you are a seagull. I want to see some seagulls out there, hopefully gliding in the sky. It's a perfect day. We're moving as if we're seagulls, as we're imagining the seagull in our mind. Okay, you guys look very peaceful. I like seeing that. Okay, now we're going to change it a little bit. And now this guy's having a little bit of fun with it. But this guy's moving a jackhammer. A jackhammer is a very different experience than a seagull, right? So when he's using his jackhammer, it's jerking his body around. It's, you know, he's having to rip up some pavement or some dirt. So what what I want everybody to do is I want you to hold an image of the jackhammer as if you're moving your body, as if you're the person that is moving that jackhammer. So actually feel yourself moving the jackhammer. Okay, we're going to do one last exercise and then you can sit back down. Now what I want you to do is I want you to hold the image of the jackhammer in your mind. Everybody's picturing a jackhammer in your mind. And at the same time you're picturing the jackhammer, I want you to move your body as if you're a seagull. You're imagining the jackhammer and you're moving your body as if you're a seagull. Okay, good job. So hopefully what you found is that it's more difficult to move like a jackhammer or a seagull when you're imagining something different. Did anyone experience that? When you're picturing a seagull, it's easier to behave like a seagull. When you're picturing a jackhammer, it's easy to behave like a jackhammer. When you start imagining you're a seagull and moving like a jackhammer, it's a little bit more difficult. Yes, difficult. Woo! Okay. So when our patients are imagining, I'm never going to get better, this is not going to help me, and they're trying to make it, it's not going to be smooth. We want those images to be consistent. Okay, hopefully. Okay. So how do we change the cycle? We're almost done, you guys, so hang in there and then we can get to questions. So how do we change this cycle if we have a patient that's in a negative mindset, and we know that's getting in the way of their program? They're down on themselves and they're down on other things. How do we change the cycle? Well, one of the things that we can do is we can help the patient notice. We can help them become more aware of the things they're saying to themselves. And we can teach them about the cycle of how our thoughts create our success and our results, and help them understand that when they're talking negative and they're thinking negatively, how that is getting in the way of the goals that they're trying to reach. We can help them come back to the present moment by doing some breathing. I bet many of you use breathing in your practices when the patients are fearful or they're anxious. A lot of times I'm using belly breathing to kind of bring them back to the present moment, calm down the nervous system and the mind. The other thing that we can do is we can work on distraction. Sometimes I'll say, hey, put a playlist on your phone, and when you start to go into this negative cycle, have an upbeat music that you play, or call a friend and try to tell your friends, when I call you complaining, switch me back to a positive. If you can, tell the patient to go on a walk or change their environment, change their posture. Oftentimes, if we're slouched over, it's easy to get depressed. If we sit up straighter, we're likely to have a better outlook. One of the things that I use all the time in my practice is visualization. Visualization is a way of activating the same neural pathways when the patient is visualizing in their mind what they want to be able to do. So if somebody wants to be able to run or walk and they can't even stand, I will tell them, for 5 minutes a day, I want you to be the person that you will be when you are well. I want them to see it. If they want to be able to run on the trail, I want them to see themselves pounding on the trail. I want them to hear the wind whistling. I want them to pretend and feel their chest going up and down with their heavy breathing. Whatever it is that they want to be able to do, I want them to see it in their mind's eye. We are programming those neural pathways for success. Our mind does not know the difference between real and imagined activities, and it's a great way to speed up the progress. Olympic athletes use this all the time. If you watch the Olympics, I bet you have seen it. There's a great study that was done out of Chicago, University of Chicago, where they broke people up into 3 groups. One group, they had them practice free throws for basketball. They had them do that for 1 hour. What did they do? They had every group practice for 60 minutes for 30 days. Okay. The next group, they had them not touch a basketball, but they had them visualize as if they were actually throwing the basketball into the hoop with a free throw. And the last group, they had them do nothing. In the group that did the free throws, they improved by 24%. In the group that only visualized the free throws, they improved by 23%. The third group, of course, didn't improve. We have the ability to help our patients improve by working with the mind to help them reach their goals faster. More almost done, Connie. Hang in there. So we've talked about the first 7 seconds. We've talked about body language. We've talked about shared decision-making, patient-centered care, and patient engagement and motivation. I hope today you took some tips away that you will use in your practice to help your patients become more motivated. Thank you so much for having me. I'm so excited to talk to you about all of your questions.
Okay, Molly, we're going
Yes.
to have case studies before we do any questions because we actually have 7 people to present to you.
I love that. I have them. Is that the ones that you sent me?
There's more. So, Mr. Tan, can you come on camera so we can see you?
Okay.
Where are you?
Yeah, Connie, you see me?
Oh, I can't see you, but I can hear you. There, I can see you. Okay, Mr. Tan, will you present the first case to Molly and then you call on the next person, you run this part of it?
Yeah, okay.
Molly, to get to the 7, we'd only have about 5-minute, 4-minute, 3-minute response from you.
Okay, great.
Okay.
And
Thank you very much, Connie and Molly. All the question that I tell everybody to sharing the case is, can you have some PTs bring her to motivate the patient to this presentation? And this is a unique way that can use to motivate the patients. The case number 1 is from the neuro PT at the Bangkok Hospital headquarters. And then next, a neuro PT2, and next is occupational therapist and MSK by the BHQ2. Okay. Case number 1 is from Kun Pik. Okay, Kun Pik, please turn on your camera and then please read the case to present Molly, and then you can share and please Molly explain more or give the suggestion to us. Thank you very much.
Hello, good morning. My name is Pong Sili from Bangkok Hospital. I'm neurophysical therapy. So I have the stroke case. She is a recurrent stroke patient. She is 67 years old. The first stroke is on 2020 and the recovery is full recovery. The second one is on 2023. She has mind impairment on the right side. And during the admit, she feel depression and feel afraid about her condition. That because she have to back home to stay with her husband, that he have a 72 years old, that is an old man. So she afraid to back to stay with him. So we show that we do the outcome measurement for her, and the outcome, all the outcome is it show that she getting better, but she's still afraid about how to stay at home. So we try to do the like safety in the house checklist for her to make sure the problem that she have in her mind, what the problem that she have in her mind. So the safety in the house show that she afraid to stay at her home, like she afraid to walk in her house because have a lot of step, and she afraid to walk to the toilet and stay with her husband. After we do the home environment adjustment for her and try to practice in this goal, she feels more happy and feel more motivation to do the exercise with us.
wow, you did a great job. So you switched up many things to help meet her where she was.
Lee, I don't want to interrupt you, but can you take down the screen so we can see you all better?
If I knew how to do that, I sure would.
Just stop sharing.
All right.
Share.
Stop
bottom.
video. Share.
Just hit the share and you should stop unsharing.
Share my meeting window, share multi, oh, stop. Okay, let's see, stop.
Thank you. Okay.
Thank you.
Yeah.
Techno. Okay. Okay, so it sounds like in this case, you don't have questions. It sounds like in this case, you were showing me, which I love, how you turned the patient around. Am I correct on that?
Yeah.
Awesome job. Really, really good. So it sounds like maybe what you saw was you saw the outcome forms were not meaningful to the patient. The patient was still afraid. So you kept on digging and coming up with other ways to help the patient be less afraid. Is that right?
Yes.
Awesome job. Really, really impressive.
What would be your question to Molly?
Is that right that I'm do like this to prove her problem?
Right.
To
I
prove
think you
my
did. Right. I think you did a really good job. You didn't just start with the first thing and say, hey, my outcome forms show that this is the case, and then just kind of give up there. You're like, okay, well, what other things can I do to help the patient feel more comfortable, to help the patient see that they're further along than they are? So you did a very, very good job.
Okay. Thank
Nice.
you. Thank
Very,
you.
very, very good job.
Okay, I'm done. If you like to sharing more, which way that we can improve or give some motivation to this patient?
Your question is, how would we give more motivation to that patient?
Yeah, or to the family to know in another point that the patient can maybe like a self-esteem or feel like a more confident.
More confidence. Okay. One of the best ways, can you think of one of the best ways if you're doing something that you don't feel confident in, what's the best way to become more confident? Is to do something when we don't feel confident, to do it anyway, to kind of give them a little bit more challenge and do it again and again and again. And each time we do something that we don't feel that is a big stretch, we become more comfortable doing it. Does that make sense? I'm not sure.
Okay.
That wasn't the best answer, but how we get confidence is by doing things that we're uncomfortable with a guide by the side, with a therapist by the side, and having somebody stand by us and witness our fear and saying, hey, I'm right here with you, and showing them how they can improve, and standing beside them while they're afraid. And then each time they do it, they will become a little bit more confident in their abilities.
Okay. Yeah. Thank you very much for this case.
You're so welcome. Thank you for bringing it forward.
Okay,
Okay.
Molly, I have questions about this case. Is
Okay.
it necessary for us to gather all family member, husband, son, daughter, or anyone who stay with the patients, gathering and like a team meeting? Is it good,
I think
or
it's
only we approach the patient first?
is it important for the patient to have the family there?
Should the patient bring the family, or is it up to the therapist to get the families there to
Right.
get them on the same page?
That wasn't towards me, right?
No,
Or
that was towards you.
that was, okay, that was towards me.
Is
Okay.
that right, Dr. Sushila? Did I say that right?
Yes. Is it PT role to correct all the members, family members, to set up the team meeting, so the family knows the patient's fear, and the patients know the family support.
Right. No, your HIPAA guidelines are probably a little bit different in Thailand than they are.
They're
You-
same, Molly.
They're the same. Okay, thank you for saying that, Connie. I
And if
appreciate
it's
that.
if it's in the inpatient setting, I could answer that. It is up to the um, the clinician, whoever, if it's the physician or the RN coordinator or the PT, to actually set up the care conference with family and patient so that everybody understands the challenge being faced. And um, we we have to make sure the patient agrees that they want all those family members there, of course, because sometimes we find out there's a case against one of the family members or have not spoken for a while. But so we get a patient approval, but it is for us to establish. Usually it's the nursing manager on the floor that does that.
Mhm. And and so we want, of course, to have talked to the patient. I'm not sure how this happens. Connie, you can correct me if I'm wrong, but I would always direct the patient first and then understand we want the family there so that they can help support and guide and move the patient along when they get home. Is that what you're thinking, Connie?
That, and so that there's no misconception like of what the patient wants, what the family wants
Mhm.
is so different. It brings everybody onto the same page of the progress the patient is making and the expectation.
Mhm.
But we have to be very careful that the patient wants that to happen
Exactly.
if they have all capacity.
Okay, my point is the therapist consume long time to treat the patients, so they may detect or earlier detect what the patient's concern. So they need to like activate code or activate the team meeting. But I think do they need to get permission from the patients about that team meeting, because the patients sometimes want only privacy or about that problem,
Right.
maybe about the
Yeah,
husband something.
yeah. So that's a touch and go at OHSU. We just had this conversation yesterday about a specific patient that did not want family to know, but family was very much in the dark. So we asked her to identify who she wanted to have at the meeting, gave her a choice, and then said, we really need the person that's making decisions for you while you're in the hospital here. We need your husband. And we kind of helped with her making the identification of who should be there. But if a patient declines to bring any family member to the meeting, usually what will happen is nursing will speak to the family as they come to see her at the bedside and bring up what was discussed at the case conference. So it's just a touchy situation, right, Dr. Sushila?
Molly, according to your experience, do you think family support help or sometimes not help the patient's motivation?
Oh, 100%. You know, I bet you can all think of your own families. There's probably people in your families who you think are super motivating, and other people in your family who bring you down, who start to go, "Oh, I thought you said you were doing better at your walking. I saw you trip." So we all have different kinds of family members, and I think we need to educate the family to say, let's start to really notice the great things, the changes that they're making, and the things they're doing right in ways that we can encourage them instead of just pointing out all the things they're doing wrong. So I think family is very, very important early on. But just like every family, there's people who are super motivating and encouraging, and other people you could feel you're on top of the world and they could make you feel this tall in no time flat. So
Can we go to case 2?
Okay, thank you, Pongsili, for the case sharing number 1. Okay,
yes,
case
thank you
sharing
so much.
number 2. I'd like to give the mute. Please show your camera and then please share it from the neuro PT. น้องหมิวอยู่ไหมครับ
อยู่ค่ะ
โอเค
Hello
จ้ะ
I'm Shananya from the Bangkok Hospital Neuro PT for my case the Thai female patient 21 years old the patient has a history of falling two times therefore she is afraid of standing up or walking as a result she does not want to do physical therapy does not want to exercise or standing up again because she's afraid of falling. The physical therapist take time to get you to understand the characteristic of the patient who is very worried and doesn't want to be a burden to the family and is afraid that if she fall again it will cause hardship to the family. The physical therapist explain the benefit of the exercise and standing and always tell the patient that they have a good strength and can do activity, but it must be done gradually and be more careful. The patient will start the familiar therapist and can do and will be more confident and cooperative more. Thank you.
Thank you. That was excellent. So you were explaining how you broke it down to make the patient more motivated. Is that correct?
Yeah.
You did a great job. You did a great job. Thank you so much for explaining that. One question that I have is they were afraid of falling, so I can understand why they wouldn't want to be upright, but what made them afraid of exercising? Do you remember?
Because she thinks when the exercise must to the standing and the walking, then she don't want to do the exercise anymore.
Okay, so would she have been comfortable? I love your solutions, by the way. Would she have been comfortable exercising, getting stronger in a seated position or a lying down position? Would that have been something to incorporate in the beginning? Or no?
Sorry, can do again, please? I can hear that.
Okay, sorry. So I was just curious if she was afraid to exercise, another way that might have worked for motivation, if she was simply afraid to exercise standing, is to get more trust doing exercises sitting down. So she could get stronger, which would obviously lead to more control in standing.
Yeah.
Okay. So would that have
Uh,
been something that you would have done?
Molly, like you talked about breaking it down in steps, could you kind of give her that example?
Right. So instead of just thinking, okay, the patient has to get up and walk and the patient's afraid, one of the things that you can do is start to develop trust with the patient by meeting them where they are. If they're stopping and they're saying, I'm not going to do this, we can say, okay, let's see if we can do some of these exercises sitting down or lying down, because when we do this, our muscles get stronger. And when our muscles get stronger, we can feel more stability when we stand. And when we have stability when we stand, we might feel safer and be able to take just a little bit more risk. So starting with very simple exercises and moving to sitting and then moving to standing. So
yeah, for my program, I start on the bed first and like active exercise, and then step up to the sit on the side of bed. And when the patient it have more confidence, we will stand with the get it like a walker first, and it's like a step by step for the marching or stepping, and then have she have a confident more, we will try a little bit step walk forward or backward, something like that.
that is an excellent idea. And you did a great job of meeting the patient where they were at the time. Instead of saying, no, we have to walk now, you were able to understand that they weren't going to be motivated, that they needed to back up a little bit. So good job of recognizing that. That's really awesome.
Okay, case number 3, Mr. Tan.
Okay, case number 3 is the occupational therapist sharing by Nam.
Hello, I'm Gulanan from occupational therapy. I'm gonna talk about the motivation problem of meet of both of Thai people and foreigner is cause for mood, depression, self-esteem, not understanding the importance of OT training, feeling that OT training is trying and difficult, and we talk about like how to adjust the motivation. We try to adjust the approach and explain the reasons and training guideline to patient and relative. All multidisciplinary team and family help to encourage and explain the reasons for the training to patients, or we adjust the training and choosing activity appropriately, or we try to adjust equipment or training and environment too. And about the result of all of this that we adjust, if the patients can communicate understandably, we will cooperate in the training. And however, if the patient with suspect cognitive impairment may not yet be motivated, so OT will try to create training that is most beneficial to patients. Yes, thank you.
Thank you. That's,
Molly, did you hear childlike and depressed?
I did hear childlike and depressed. It sounds like the patient, from what I heard you say, the patient does not feel like they're improved, right? Did you say that?
Yes.
Okay, so were you using things that were important to them, or were you using outcome forms? Were you, if they can't see their progress because they're feeling down and depressed, were you able to show them specific things that they weren't able to do that now they are able to do?
Yes, we try to like explain to all patients and their family too.
Good. That's really, really good. So so in the end, was the patient motivated to participate in therapy? It sounds like they were a little bit more motivated to participate. You understand or no?
Did you change what you did to make them more motivated?
I like in occupational therapy we change like or off like approach or like some training for like in like can to correct with any patient, and we choose things like this.
So it sounds like she was modifying what they were doing to try to meet the needs of the patient.
Yes.
Well, and I'm wondering, Molly, did they ask what the patient liked to do first? Or
That's
what they wanted to do? Or just took them to a specific equipment they had that works on hand function or shoulder function?
That's a great suggestion, Connie. So again, going back to what's important to the patient, sometimes if they're not motivated, giving them a choice of a couple different things, or asking them, like Connie said, what do you want to be able to do? And one of the things I think I heard you say, if I'm wrong, I hope I'm not wrong, is that you said that the patient said they're not better. So if you think back to what I talked about in the presentation, if patients aren't perfect, if they're not back to normal, oftentimes they will say, I'm not better. So helping patients understand there's a spectrum to better. Does that make sense?
That's right.
So better isn't just I've reached the end goal. Better, they are moving towards the end goal, which shows improvement. But I like Connie's idea is excellent, is if they're not motivated, is number one, giving the patient more ability to choose what's important to them, what they're in the mood to do that day. And also, you know, sometimes we think we have to do this whole big treatment. Sometimes I'll say, if a patient's resistant, I'll say, you know, would you be willing? I didn't say that to that particular patient, but we could use an example of, would you be willing to ride the bike for 30 seconds? Would you be willing to participate for 3 minutes? So we're breaking it down into an increment that is much easier to say yes to.
For this for this challenge case, if the patient have a bad mood today, they don't like to exercise today because I'm from the mood. That's why that Molly you explain more in the first slide. If the mood is not okay, you try to like a relaxation, have a breathing exercise, something like that, or
Yes.
anything else you more suggestion.
Yes, several suggestions. Thank you so much for asking. And I absolutely breathing just calms us down. It opens up our spaces. It brings us back to the present moment. If we're in a bad mood, we're thinking about something from the past or something from the future. And if you can bring patients back to the center of just in the present moment, by having them do breathing, by having them focus on the surfaces that they're in contact with, their bottom in contact with the chair, their feet in contact with the floor. If a patient is a sports patient and they come in a bad mood, I make them skip around the gym because it's very difficult to be in a bad mood when you're skipping. Now I realize that neuro patients cannot skip, but we can turn on music, right? If we know a patient's coming in and they're in a bad mood, we can have some music on our phone. We can look around the clinic and find the brightest spot that is just the sun's coming in and it's just a beautiful setting. And maybe shift to treating the patient there to help change the environment to help bring their mood up.
And remind on visualization again.
Yeah, visualization is an amazing tool. Again, if you don't use it personally, I'm hoping that when I'm there that we can all do some visualization together. It's a very, very powerful tool. Your mind doesn't know the difference between the two, and it's setting up those neural pathways. So Connie, you're exactly right. The patient's having a hard day. So maybe one of the things you could do is you could take them through a visualization of them being successful doing what they're doing. You know, it's interesting. This is on the opposite of what we're doing here, but I think everybody can understand it. Sometimes patients that have a lot of pain and I can't quite figure out what's going on, I'll say, okay, I want you to close your eyes and I want you just to imagine turning your head to the right. And they'll go, that hurts. They haven't moved at all. And so then I'll go, let's start there. Let's just start by visualizing. They're not even moving. Let's start by visualizing moving your head to the right. Okay, now let's visualize in your mind moving your head to the left. And okay, now let's imagine that you're standing up. And when we meet our patients at the level of that level, they're really bought into that therapeutic alliance. They see that we trust them, that we're willing to meet them where they are.
Okay, Mr. Tun, pick one
Okay.
last one.
Yeah, I will use the visualization to close my eye and choose another case from my list.
I like it.
Love it.
Yeah, I will choose 1, 2, 3, 4, 5. Okay. The last case is from Payatai. Kun Kero, please show your case.
Show your case.
พี่กบครับพญาไทใครเป็นคนแชร์เคสครับ
ค่ะจ๋าค่ะ จารุวรรณค่ะ
Are you
Turn
ready?
on microphone.
Hello
Hello.
ครับ I hearing you.
Okay ค่ะ So we are from Payathai 2 Hospital. Today we're gonna present about one case study that we have met. The lady who the Thai female 22 years, her diagnosis was gallstone with combined duct status post laparoscopic cholecystectomy with endoscopic retrograde cholangiopancreatography on April 6, 2023. Okay. Her she got like exploded with collection drainage with gastrojejunectomy and drainage abdominal abscess, and she done 4 times of laparo. She refused to eat and drink, and she has the depression also. So the doctor consult occupational therapy on July 23, 2023 for swallowing program cognitive training and hand function training.
Yes. Sorry. Yeah, I'm occupational therapist from Payathai 2 Hospital. My name is Jaruwan. And about this case, her impairment has delirium. She has delirium, and we use the confusion assessment method to assessment. Sometimes has positive and sometimes negative. And her big problem is she has poor self-control and her emotional always cry all the time and poor social skill. She always have no face expression, no eye contact. Poor ADL also, poor hand function and ADL dependent. About the treatment, when she refused therapeutic session, she always screaming, angry, and cry. No cooperate. OT, we use the purposeful activities such as makeup class, singing, dancing, and recreation activities that are her leisure activity before she got sick. About social skill problem, we do group therapy 1 time per week and use parallel group to encourage her social skill, such as cooking class, recreation class, and music class. We ask her family to join some therapy section, and sometimes we change environment. We use the therapeutic use of self, such as understanding, acceptance, and active friendliness to make relation with her. Sometimes we change her environment when she have lunch. We change the room, pick up her to the exercise room, occupational room, to sitting with her and have lunch with her, to be friend, and after that, her corporate increase and she tried to do feeding and eating by herself, and cooperate with the PT also when have an ambulation. Yes.
Yes, you did a very, I love all the things that you were.
The question is, if this patient has depression with functional limitation like that said. So, and we do not have any psychologist, and the doctor treat only medication and send physical therapy and occupational therapy. So do you have any suggestion for us to improve this patient?
Well, first you did I loved hearing the things that you did do. I think you did an excellent job of adding lots of different meaningful activities to see where you could connect with the patient. I'm very impressed with the way all of you are doing that. You're not just trying one thing. You're trying one thing. If that's not working, you're trying something else and something else. And that to me is very impressive. So I like that. Patients that are depressed are, can be more challenging, but thinking of the kinds of things that I just heard you come up with, changing the environment. Maybe if you're allowed in Thailand, taking the patient outside, letting them feel fresh air. Where the space that you're working in, music, as you were talking about playing, listening to music. In this particular case, it sounds like it would be difficult to work on helping the patient understand how their thoughts might be contributing. Is that accurate?
Yes, we try that.
Okay.
And we try, yeah.
And I certainly never want to come across as I'm coming in as the expert, because when I'm reading your case studies here, I'm very impressed by the things that you're doing, and I think that we can all learn from each other. So I'm happy that this is a collective conversation.
Molly,
Yes.
what do you think about, I wonder, did you do the patient-specific functional goal form like with them? Did you see what her goal was? And what do you think about just listening to her for some sessions? Molly?
I think that is an excellent idea, is listening to the patient, understand, like in America, we call it drilling down, really going to the next level of understanding of the patient and not feeling like we need to. We're going to make more progress when we kind of listen and understand where they're coming from and understand what they want to do and what is meaningful to them. Listening.
I was
Go ahead,
just
Mama.
thinking about how I had so much fun having lunch with this group. So her sitting having lunch with you probably just made her worlds. And that was like the perfect thing to do.
Such the perfect, and because you know why, another reason why, as Connie just said, it makes her feel included. It makes her feel part of your group. It makes her feel respected, and that can go such a long way with patients, with anybody, with a human being, it goes a long way.
Thank you. Thank you. I think the big problem is she not cooperate, and we cannot do anything to her. We cannot get improved, and we try to how to get her cooperate with team, and try to talk with her husband how to do. And after we have we have condition to her, and let the husband to do the same thing. And in the daytime, patients stay alone. And so that may be the difficult to get improved for depression. And family will come to meet her after he finished work, and at nighttime, also at nighttime, and that time he stay alone. I think that we will be friend with her. It's just not only therapist, not be friend. Maybe she had, I think that she had need to someone to be friend, and stay with her, and be kind and acceptant, because in her thinking, thinking about her sick is very severity, not improve. He cannot walk. She always say that, and she always cry. We discussed with the team physical therapist to design the program, and the last month she stayed in hospital. We do the session together about 1 hour, 30 minutes for activity like that she need. She love to like dancing, like sing a song, and aerobic sometimes. And after that PT ambulation, and the progressive will improve a lot, a lot of improving. Yes.
That's great. It's another thing that just popped into my head. You have some amazing ideas there, is making sure, like, can you imagine how great we would feel if we were home all alone, just sitting there waiting for somebody to get home? But are there things that are there, I'm not as familiar, but I know I will be very familiar before I get there, of the kind of community events, like, are there movies that she could watch with somebody else, or do they have music playing where she could go sit in an audience and listen to music? I had one patient, she wouldn't do much of anything. And I talked to her husband for a long time and was like, what did she used to like to do? And he said, she is an amazing dancer. Now, this woman could barely stand up and could barely walk. I put on some music and this woman became a different person. She was transformed. Her husband told me that she used to be somewhat of a professional dancer. And I asked what her favorite song was. I put it on my iPhone, and the woman who could barely stand was dancing around the gym. I was almost ready to fall over. So sometimes asking something from their past that they used to love to do and bringing that in, or having them do a group exercise, not for the purpose of participating, but just being with other people to feel like they're enough to just be part of a group. You know what I mean?
The thing I was thinking about is creating a schedule for her during the day, like to remind her, turn on the music.
It's a great idea.
Watch your favorite TV. So things that call your friend or have the friend call her, like help create a schedule so she's not lonely. But also the husband, could he maybe hire somebody to come in to be with her a couple hours of the day? And maybe a private OT coming to the house for her to get stronger? I think she's completely lonely, and so she's depressed.
Yeah, she's depressed because she's isolated and she's not just not doing her PT or OT, she's not doing anything.
Do you guys have community centers? Like we have senior centers where a van will come and pick them up, and it's usually in a neighborhood, and they go for lunch, they play cards, they might sing, but it gives them time out, but somebody comes to pick them up. Do you have anything like that in Thailand?
My hospital, we don't have any community service like that.
Oh, you don't?
So,
We should start
so that's
one.
why we try to
Coming.
adapt everything that it should be benefit for the patient.
Mhm.
Yeah, that's kind of in my mind, Connie, that's what I was thinking of, in the kind of a community,
Yeah.
a community thing.
If
That would be a good thing.
is she home now?
Yes,
she-
she already discharged now and start to go to work already.
Oh, good. Okay, so she's got productiveness.
Yes. And she's got community now. She's going to work probably.
We are way over time, but Tan, if you would like to send the other cases to me, I will get them to Molly and we can maybe do a written responses on ideas, as well as the first ones I have. Molly, maybe we could go through and add some other ideas.
Would love that. You bet.
Okay,
I will
yeah.
send out the presentation. Mr. Tan, you will collect evaluations.
Yep, right. Everybody please do the oh, I forgot the word. please do the evaluation link. I sent everybody in the chat already. Okay, thank you, Kun Warakan and Kun Jaruwan from Priyathai too for the case sharing. And everybody in the sharing case today. Okay, thank you, Connie. I will tell the PT and OT from another side that will sharing case to you and Molly. They will will get the best suggestion. I hope that.
And Kukinka, that you did that case study section for us, Mr. Tan. You're fabulous.
Thank you so
Thank you
much.
very much.
That's amazing. I love hearing all your ideas.
Dr. Sushila, do you have any last comments?
I would like to ask something. The role to activate the team meeting or the family together, is it the therapist role or the case manager role?
For Actually, for OHSU, it is the case manager role or the stroke, like if it's for a stroke patient, it would be the stroke coordinator's role. So yes, it is the care manager's role, but it is the therapist's responsibility to request if they feel a case conference would be important. So they should go consult with the physiatrist to agree to ask the case manager to set it up. Yes. Good point, Dr. Sushila. I forgot that BHQ has case managers now.
Right now, we try to improve the case manager role, give them know their role, definitely.
Yes. And you know, we might have that in our care manager job description. Would you like me to send that to you?
Oh, yes, very good. And
Anything for
when
you.
the candidate here go to OHSU, you show them the case manager responsibility and job.
Yes, actually, we just talked about making sure that people knew everybody's role on the team and how we all interact, but what is each role, especially in the inpatient setting. So definitely we'll do that, Dr. Sushila.
Thanks so much.
Anytime. Molly, Dr. Sushila loves French fries with me, like you like purses with me. And her daughter lives in Seattle.
Oh, you're kidding. I love Seattle. I went to college in Seattle.
But I love Oregon, no tax.
Exactly.
That's why we're here. Thank you, Sawadika, everyone, for being here for 2 hours and 13 minutes. We ran over, but it was such an exciting topic. Please send to Pascontan any questions or Jenny we can answer more questions throughout. And then I would love Molly, for everybody to consider having Molly come as a guest in the fall to be able to really work with you in person. So we'll talk again soon. Have a good evening. Tiny hearts.
Thank you so much, Connie and Molly.
Thank you.
Good evening, Connie and Molly.
Good evening.
Thank you so much. Dr. Wannapha not able to turn on her microphone, so I will pass the thank you on behalf of her. I will see you. Connie, we got some name list for the candidate that you want. We shall able to send you soon.
Oh, that is so fabulous. I'm so excited. Thank you so much. Nice to see you.
And have a good
Bye.
night dream in
Have a
Oregon.
wonderful dinner.
Thank you. Have a good day at work.
Enjoy.
Thank you. Bye-bye.